I will be presenting a pilot study on the clinical outcomes of intra-articular triamcinolone injections in diabetic and idiopathic frozen shoulders. Coming to a general introduction of the condition, adhesive capsulitis or frozen shoulder or scapulohumeral periarthritis is a condition where there is restriction in both active and passive movement. Though the exact pathophysiology is still under research, it is more common in diabetics and patients with autoimmune thyroid disease. Again, more commonly seen among women in 40 to 60 years. And people with diabetes are 5 times more likely to have frozen shoulder than people without. And the prevalence of frozen shoulder in people with diabetes has been estimated to be 13.4%. It can be primary, post-traumatic, or post-surgical. And the primary underlying pathophysiology is that there is inflammation of the shoulder joint initially, which eventually ends up resulting in fibrosis of the shoulder joint, which causes decreased range of motion and impairment of the day-to-day activities of the patient. So coming to the clinical staging, there are 3 clinical stages described. Stage 1 is the freezing, stage 2 is the frozen, and stage 3 is the thawing. So the freezing stage is the initial stage where there is inflammation, where the patient has gradual onset of pain, and it's in the initial 6 weeks to 9 months of the condition. The frozen stage is where fibrosis sets in and there is decreased range of motion, and this is between 4 to 9 months. The thawing stage is where there is gradual return of motion, and it can take somewhere around 5 to 26 months post onset of symptoms. So coming to the arthroscopic stages, stage 1 is patchy fibrinous synovitis. Stage 2 is where fibrinous adhesions start forming. And stage 3 is where these adhesions lead to contraction and eventually resolving synovitis because the inflammation settles, but fibrosis sets in. And stage 4 is severe contraction. So as you can see in this image, there's an arthroscopic view of the normal shoulder and versus a frozen shoulder, where you can see there is intense inflammation of the joint. So coming to the aims of our study, they were to study the clinical outcomes in post-triamcinolone injections in diabetics and idiopathic frozen shoulders. And we also attempted to establish a correlation between HbA1c levels at diagnosis in diabetics with reduction in pain and occurrence of relapses. So the materials and methods, this was a retrospective analysis of 61 patients over a 5-month period, of which 36 patients were excluded due to lack of follow-up and presence of coexisting inflammatory pathologies. For the purpose of this study, we also excluded injections into the subacromial space. 25 patients were followed up through electronic medical records for 1 and 3-month follow-ups post-injections. They were divided into groups of diabetics and non-diabetics and 40 mg and 80 mg triamcinolone injections. For the purpose of this study, we used more than 50% reduction in pain as resolution bar a favorable clinical outcome. So coming to the techniques of intra-articular injections that we used, I will be just briefly going over them. We used a posterolateral approach in our institute using the Philips Epicalete scanner with a 18 to 4 degrees probe, 18 to 4 hertz probe, sorry. Posterior approach was used, and the position was lateral and the shoulder was internally rotated. So we located the spine of the scapula by palpation like so, and then you proceed to position your transducer parallel to the spine of the scapula. The other equipment that you'll need is bupivacaine 0.25% that we use here, tricort injections, which come in 40 mg vials, and the Quincke needle. We use the 20 gauge Quincke needle in our institute. So coming to the method, the transducer is placed immediately below the spine and parallel orientation. You identify the myotendinous junction, which is here. This is the infraspinatus muscle. This is the infraspinatus tendon. So this will be the myotendinous junction. Between the humeral head and the glenoid is where you target your needle. This was the needle, but the track could not be visualized perfectly in this patient. So this is how you approach. You have to take care to not hit or damage the glenoid labrum, which is why it's a good idea to always stay 10 to 15 millimeters away from the glenoid labrum. After this, after you clean and drape the patient, you administer lignocaine, and then you inject a 22 gauge spinal needle at a 45-degree angle, lateral to medially. and distend the joint cavity with 10 ml bupivacaine. After which you can inject 1 to 2 ml triamcinolone as per whatever the patient's requirement is. So coming to the results of the study, the overall mean age was 54.2 years in the patients. The diabetic group tended to have older patients with a nearly equal sex distribution, as you can see. The age here was 55 years and 51.4 years in non-diabetics. The frozen shoulder, which was idiopathic, was more common in women. As you can see, we have 7 women compared to 2 males in the non-diabetic group. The average HbA1c levels of all of the patients combined were 7.53, and 64% of the patients presented with left-sided pain. Coming to the doses of triamcinolone administered, so we had some 12 patients who were diabetics and given 40 mg. Non-diabetics were given 40 mg in 4 patients. 80 mg doses were given to 4 diabetics and 5 non-diabetics. So at 1 month follow-up, no patients showed recurrence, and all patients reported a significant improvement in clinical symptoms. At 3 month follow-up, we had 3 patients in the diabetic group who reported recurrence with average time to recurrence of 2 months. 80 mg was administered in one of those patients, and 40 mg was administered in 2 of these patients. No patient in the non-diabetic group reported recurrence of symptoms at 3 month follow-up, and unfortunately, we lost 1 patient to follow-up at 3 months. So from this, we could infer that intra-articular steroid injections are a good treatment option for immediate symptomatic relief. And we could see that there were earlier and more frequent recurrence in diabetics. We had delayed follow-ups beyond 3 months available for around 9 patients, out of which we had 4 diabetics with recurrence. And as you can see, the number was nearly equal in both 40 and 80 mg doses. And 1 patient eventually in the non-diabetic group with 80 mg injection reported recurrence after 10 months. And as you can see here, the diabetic group had an earlier recurrence with an average time to recurrence of 3.25 months. Therefore, we could infer that there was earlier and more common recurrence with no significant difference between 40 and 80 mg doses. However, there is a source of bias in these results that more patients with recurrence tend to present for delayed follow-up visits, because after 3 months, we switch to an SOS review of the patients. So if the patient does not have problems, most likely the patients will not present for follow-up. Coming to the HbA1c levels, lower levels were correlating to no recurrence. As you can see, 8.1 was the average HbA1c level in patients with recurrence. So coming to the discussion, intra-articular triamcinolone continues to be a good treatment option for immediate symptomatic pain relief. At 1 month, we had 100% of the patients showing significant improvements. Our findings are consistent with existing studies, which show higher incidence of frozen shoulder in diabetics. Since we had, out of 25 patients, 16 of our patients were diabetics with more common and earlier recurrence. You can see we had somewhere around 7 patients with recurrence in the diabetic group and just 1 patient with recurrence in the idiopathic group. And an interesting finding was that we had a nearly equal occurrence of recurrence between 40 and 80 mg doses, which needs to be further evaluated with a larger sample size, because we need to investigate further the supposed benefits of a higher steroid dose in preventing these relapses. So the postulated theories for findings at 1 and 3 month follow-ups. At 1 month follow-ups, the intra-articular synovial inflammation component is acted upon, leading to a reduction of inflammation or vascular hyperplasia in both groups. However, there is earlier recurrence in diabetics, which can be secondary to decreased expression of inflammatory cytokines at the outset. So there is more fibrosis, however, less inflammation. And your corticosteroids are primary anti-inflammatory, so they will not have a medium to act on. The second is that there is a greater endothelial growth factor levels, and abnormal collagen cross-linking and fibrosis is also attributed. So coming to the limitations and challenges of our study, we had a small sample size, high losses to attrition. We had subjective evaluation of pain. which we need to modify into probably a visual analog scale or something more objective as a measurement of, as a unit to measure pain. And we did not account for the role of physiotherapy and the compliance to physiotherapy in these patients. So concluding for today, significant immediate pain relief occurs post-triamcinolone injections in both idiopathic and diabetic frozen shoulders. However, the delayed effects in diabetics are reduced with more frequent